We will take a closer look at one of the most serious questions ever to confront society and the church. Who lives, who dies, and who says?
Support for physician-assisted suicide is generally based on three assumptions. Number one, that you have a terminally ill patient who will die within 6 months. Number two, that that patient is mentally competent to make a rational decision for suicide. And number three, that the patient is in unbearable pain that cannot be relieved. The problem with these assumptions is that they're all wrong. They're all fallacies.
I made a house call on a patient just a few weeks ago who 3.5 years ago was found to have cancer in his bowel, which had spread to his liver. And he was told at that time he had less than 6 months to live. And he enrolled in hospice and had good hospice care. And then 6 months later, he became what I call a hospice graduate. They said he no longer qualified for hospice care after 6 months. And he, 3.5 years later, is still living at home.
When people think about death, that's what they think in terms of that it is going to be very, very painful. There's going to be a tremendous amount of anxiety. But with the pain medications and with the anxiety medications, through home hospice care in particular, they were able to medicate Rachel, keep her very comfortable and yet very alert and aware to the degree that she wanted to be. She was able to talk, to visit, to do things from her bed as she was able.
A related fear driving the physician-assisted suicide movement is the fear many people share regarding the loss of dignity, becoming confined to a wheelchair or a hospital bed, losing control of one's essential functions. Author and disability advocate Joni Eareckson Tada has faced those fears for many years.
Society defines quality of life as those combination of factors that make life agreeable or comfortable or preferable. Kind of like asking someone, do you like your life? And the trouble with that question is that it bases life value on whims and personal preferences. And I can say from a wheelchair that there are plenty who don't like my life. But if I listen to my hot and passionate emotions all the time, I'd be reaching for pills constantly. No, when it comes to life value, we need to base it on something far more stable than one's whims and fancies on any given day when they might be hurting. A lot of people think that loss of dignity is connected with whether or not you can go to the bathroom by yourself, or give yourself a bath, or whether or not your hands work, which incidentally mine don't. But I can speak from personal experience and say that loss of dignity has nothing to do with bodily limitations or functions. Loss of dignity occurs when a person who is suffering forgets the worth of his own soul.
Hi. Well, I just love a couple of things they bring up in that wonderful clip from that tape. The first thing I want to talk about is the doctor saying he had a patient where cancer went into their liver, and they were given 6 months to live, and 3.5 years later, he's at home having a ball. He was a hospice graduate. Is it ever possible for doctors to be wrong? I mean, is this just a strange concept here?
No, I think I have enough gray hair to have been wrong many times with my, I think, lack of hopefulness sometimes in cases that did astonishingly well. I remember having a conversation with one of my patients that maybe because she had lung cancer and I thought it had spread to the liver, that there really was nothing that could really be done to cure it. And I said, one option would be to just support you, not do any more tests, and plan on things like going to Hawaii and enjoying your life fully until the cancer overcame you. But I said, just to be sure, let me take the films around so you don't have to go to the consultant and all that and spend your time in the hospital. I'll do that. And sure enough, the consultant and I agreed, let's just biopsy these things in her liver to be sure and be able to give her a better prognostication about what the future might look like, be able to help her better with what it might be. It turned out the liver nodules were cancer, but it was a different kind, kind that was treatable. And that then made the cancer in her lung, not related to this, and it could be resected. To make a long story short, we resected both, and she was doing fine, went back to being a hairdresser, worked in that job for several years, then comes back and her eyes are crossed 3 or 4 years later.
Yeah.
At that time, she has yet another cancer. It's now in her brain, and you'd sort of say, well, this is just horrible. This woman's had 3 different cancers, and she has. Well, we resected the brain tumor. She went back to work as a hairdresser. And the long story short, she had a wonderful life for almost 7 to 8 years, reconciling with her family, having a sense that every day was precious because she had really come close to a death prognosis from her doctor. That would be me. And that illustrates very vividly, not some theoretical model, but the fact that even doctors like me, family doctors who aren't cancer specialists, will encounter these cancers where you'll have a sense of, gee, it seems futile, and then be absolutely astonished at how well people do.
Well, you have so many great stories. I don't know where to begin, but I want to address the issue that people, out in their neighborhoods or out in the, when they don't have a lot of background on this issue, the thought that they may get and buy into this by thinking, isn't that just being compassionate to the person? They're going to die anyway. Isn't it great to just let them decide the day and place they're going to? What do you want to say to that?
I remember being on 60 Minutes some years ago, and one of the people interviewed was a patient who was in hospice at the time. Now, she'd been in hospice for 2 years. Now, hospice is supposed to be just when you have 6 months or less to live.
Right, yeah.
Well, she said on the air, being captured by 60 Minutes, Morley Safer's little segment, that, I'm glad this assisted suicide wasn't available 2 years ago when she'd been given the diagnosis. Because had it been, she felt pretty much down in the dumps, as you might expect when you've been told that you've got a lethal disease. But she got good care. But had she been able to avail herself, make the choice of assisted suicide, she would have. And she said this. And that was important because the associate producer, who at that point had tried to be kind of neutral, she sort of realized, wow, this is dangerous. You've got people, as Johnny Erickson Tata said, who have bad days. And if you give them the tools, you legitimize it. You put an imprimatur of approval from society. This is a good thing to do if you choose.
Approval or pressure.
And pressure. And as you said at the outset, who's tracking? Not just health insurance coverage, like the Oregon Health Division tracks patients having or not having health insurance. What about life insurance? When the so-called loved ones shop the mother or aging parent around for assisted suicide, saying it's their choice. Well, I remember my mother, who was in her late 80s. She would have pain and be very much in distress. She said, I might as well be dead. Well, I'd respond and say, Mom, what's wrong? Tell me about that. And she said, well, my hip hurts so much. It's just so painful. I can't see straight. I said, well, Mom, did you take your pain medicine? And she said, well, yes. Well, when was the last time you took it? Yesterday. I'm not making this up. So I go to her medicine cabinet. I get her medicine. And by the way, we started with Tylenol before we go to things.
My son, the doctor. I love it.
So I get her Tylenol, and 20 minutes later, she said, I can't believe it's like a miracle. My hip doesn't hurt.
Oh.
Now, if the Tylenol didn't work, I would have gone to oxycodone and lots of other tools about which I'm expert.
Right, yes.
But all doctors, the good news is, in talking about end-of-life care, we have actually recognized the deficiencies of addressing pain because we've done so well. None of the 292 assisted suicides in Oregon have been in pain. That's not why they've done this.
And that's one thing people keep saying is they fear I'll either be in pain or I'll be so drugged up I won't know what I'm doing. Is there a way to be pain-free and not so drugged up you don't know what you're doing?
Well, absolutely. But you mentioned fear. And it's usually people not in pain who actually are fearful about becoming in pain.
The day they might be.
They don't recognize that with advanced pain management techniques, we have the capacity, like my father after major surgery, he had Parkinson's disease. He was asleep in an ICU with a propofol drip. That's a drip, drug that nurses can control without doctor's orders.
Yeah.
They kept him sedated for 11 days. When he woke up, he had no pain. He'd actually gone through the post-operative period with zero pain. He didn't even know what had happened to him.
And that was legal all along.
Well, of course.
Of course. And they don't talk about that.
They don't talk about that. And they titrated off so he was alert and awake, but totally in control, not fighting the respirator, so they could manage and give him excellent care. And people get excellent care in a hospice. They get excellent care with doctors as outpatient, now within a home nursing, inpatient. We recognize some of the deficiencies in the limited choices perhaps people had when we were perhaps always aggressive and not listening to patients. Well, that's not an issue. In fact, today, Luann, it's really more an issue of, can I get access to care?
Well, that's what I was going to say.
Am I going to be trapped alive with machines?
You get the stories, I know, and I just want to know, what do you want to say to the person out there that may be listening and saying, oh yeah, well, my doctor's not doing so good with my pain management. He said this is the best he can do, and it's not working. So I guess I'm stuck. I might as well take, the suicide route.
This comes up.
My guy's not getting it too well.
Just 3 weeks ago, we had a cover story of a suicide in the Oregonian, highlighted with really essentially a massive overdose she took, and they're taking pictures like this is
I
all
remember it.
a public event. Well, I got calls just like that from people confusing our group with the so-called compassionate choices.
Lovely.
And this one lady had exactly that scenario. She's frustrated because her doctor won't give her the same drugs she got in California. So she literally called the so-called compassionate choices group, which basically handles recipes for ending your life.
They're shoving you off the ledge.
They pride themselves on they manage 70 to 80% of the overdoses done with the so-called death with dignity, the assisted suicide here in Oregon.
So people need to know if their doctor doesn't get it right, that's not the end.
Well, that's what I told her.
There's another doctor that does.
I said, well, what they're suggesting to you, because you're not getting your pain managed, because you're not getting your pain managed, you should just end your life and take an overdose. Well, I had a different plan. I said, I think you need a different doctor if your doctor won't give you the appropriate attention. She says, well, will you do it? And I said, well, sure.
I think a lot of older people are very obedient. My mother was just like that. The guys in the white coats are next to God, and you don't question them, and you're obedient. You do what you're told. They come from a very long line of politeness and obedience to authority.
Most of my patients don't do that anymore.
Well, my mother was like that to her detriment, I think, but I know a lot of elderly people are shy. They're very shy, and if they don't have an advocate or a child saying, Mom, let's go, let's change that doctor, Dad, come on, let's look, let's call around, let's get somebody else. They're loyal and they're shy.
No, you're right, and I'm being lighthearted about that. But
you want to give them permission.
Unfortunately, now on the other side of the coin, we actually have cases that have been known where the daughter is actually seen as coercive by the psychiatrist who interviewed and said, it's really hard to tell who's asking for assisted suicide.
Ooh.
And there was a case, literally, of Kate Cheney, who was a lady who'd been diagnosed with cancer, and she couldn't recall really that she had cancer. That's the level of confusion she had mentally. But the daughter took her from doctor to doctor until she got the answer she wanted, which was, your mother's a good candidate for assisted suicide. And within 15 days, then her life is ended. And of course, I'm not saying there were any ulterior motives here, but nobody knows, of course, if there's some secondary gain for that family member.
I think you said it right there, and we're going to stop here for now. Nobody knows, but the bottom line is, if you're considering assisted suicide in the state of Oregon, don't do it. Would you agree?
Well, absolutely.
Don't do it. And we're going to come back and we're going to talk about more reasons why. Come back to the Woman to Woman show.
Great.